Good morning, everybody, and welcome to today's webinar, From Inside to Outside, Transitioning Out of Correctional Facilities in British Columbia. I'm Signe Berger. I'm a project manager at the National Collaborating Centre for Infectious Diseases. I am primarily focused on sexually transmitted and bloodborne infections, and I will be your moderator today. The National Collaborating Centre for Infectious Diseases is funded by the Public Health Agency of Canada to provide knowledge translation and evidence for use in public health planning and policy. We offer a range of knowledge translation and brokering, including webinars such as this one, podcasts, evidence reviews, discussions and gatherings, infographics, quick references, and much more. I would like to begin by acknowledging that NCCID is hosted by the University of Manitoba on Treaty 1 land, the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. Today's webinar will explore evidence for treatment continuity for people who are incarcerated in British Columbia Provincial Correctional Centres. It is the fifth webinar of our series titled Corrections as Public Health Settings for Sexually Transmitted and Bloodborne Infections, Testing and Care. Through evidence reviews, podcasts, and webinars, we have been focusing on corrections as public health sites, looking at the movement of people in and out of incarceration, and the role for public health in the testing, treatment, and follow-up of sexually transmitted and bloodborne infections, or STBBIs. This series aims to support public health and correctional health departments across Canada in sharing knowledge to improve practices for the prevention, testing, treatment, and care of STBBIs, including hepatitis C and HIV in correctional settings. Before we begin, I would like to mention some housekeeping items. The question and answer session today will be taking place using the Q&A tab at the bottom of your screen. Please submit questions for our speakers through this tab. You can also like other people's questions to push them up in priority. We will try to answer as many questions as possible, but it is possible that we might not get to all of them. All attendees are muted during the webinar, and the chat box for participants is disabled. The hosts will use the chat tab for extra communication to participants, so please keep an eye on that tab as well. The recording of this webinar will be available shortly after the webinar finishes at nccid.ca. If you have technical problems with Zoom, please email NCCID at nccid@umanitoba.ca. I would now like to introduce our three speakers for today. Dr. Terry Lee Seeley has worked as a clinical social worker over several decades, specializing in trauma-informed care, concurrent disorders, and social determinants of health. She has worked with youth, adults, couples, and families providing intensive treatment programming. She has been instrumental in developing residential treatment programs for women and girls struggling with substance use and mental health concerns, groups for men who are violent in intimate relationships, and drinking and driving treatment programs. Most recently, she has provided practice leadership in correctional health services, including the community transition teams across British Columbia, co-leading the program to exemplary status with Accreditation Canada in 2022. Cam Parmar has over 17 years experience of direct management and leadership in the substance use and mental health field, and is particularly passionate about improving the health system for marginalized and vulnerable patient populations. She brings a wealth of knowledge and experience in working at various levels within the provincial healthcare system. She's worked closely with various BC local communities, nonprofits, and health authorities, and has previous experience working for the Ministry of Mental Health and Addictions to support and expand much needed mental health and substance use services and programs across the province. Her journey with Provincial Health Services started as the program manager for the community transitions teams, and currently she is the regional director for correctional health services, overseeing the Community Transition Teams program. Last but not least, Dr. Sophia Bartlett is the Senior Scientist for Sexually Transmitted and Bloodborne Infections at the British Columbia Centre for Disease Control. She completed her PhD in medicine at the University of New South Wales in Sydney, Australia, then undertook her postdoctoral fellowship at the University of British Columbia. She is a co-investigator with the Canadian Network on Hepatitis C, with the Canadian Institutes of Health Research's Canadian HIV Trials Network, and the BC Hepatitis Testers Cohort. She is also the lead of the You Matter Pathways to STBBI Care in Prisons project, collaborating with people with lived and living experience of incarceration, as well as correctional officers and correctional health services. Welcome to you all. And Dr. Terry Lee, the floor is yours.
Good morning, everyone. While Cam brings up the presentation, I would just like to thank you for having us today. We're going to speak to you this morning on improving outcomes for people leaving prison by providing a multidisciplinary community transition teams. First and foremost, I would like to extend my appreciation for the land on which we are. I'm just waiting for Cam here. Okay. The land on which we provide our services. We are coming to you from British Columbia. And as a BC Mental Health and Substance Use Service within the Provincial Health Services Authority, we provide services to a diverse population, including First Nations, Métis peoples, and Inuit living in various settings and communities across British Columbia. As a provincial network, which we'll describe in a couple of minutes, we operate on the unceded traditional and ancestral lands of the First Nations. Our main office is located on the traditional and ancestral lands of the Musqueam, Squamish, and Tsleil-Waututh nations, colonially known as Vancouver. And we also have several facilities located on the land of the Coquitlam peoples, which is colonially known as Coquitlam, British Columbia. We acknowledge that our ability to live and work in these lands is today a direct benefit of policies of expulsion and assimilation of Indigenous peoples during the time of settlement and confederation and since. And the harms of these policies are many and are still being felt in Indigenous communities today. We express the gratitude towards the Indigenous people who have and will continue to steward these lands. As a Provincial Health Service Authority, we have made a commitment to amplify the voices of Indigenous peoples and working against the everyday forces of white supremacy, racism, colonialism present in the healthcare sector today. Today, we're going to speak to you about the community transition teams and our learning objectives, which we're hoping the learnings you can take away today are to focus on the importance of continuity of care in correctional health services. So as an example, we'll be speaking of the program we offer provincially across British Columbia. The importance of our community transition teams is vital, and we play a vital role in stewarding the continuity of care from inside the walls to outside the walls. The importance of client-centered care, one of our philosophies of care, is exemplified by our peer support workers who maintain a focus on this principle of care within our teams. In addition, the importance of culturally safe care is exemplified in the role of our Indigenous patient navigators. Our hope is that we influence your thinking about the role of correctional health services, the possibilities, and the outcomes that we can assist with, as well as the community transition teams as a unique program which provides services with the goal of seamlessly transitioning clients to the broader healthcare system. Just as a point of history, in 2017, there was a transfer of services in British Columbia from the private sector provider to the Provincial Health Services Authority, and under the guidance of this authority, the BC Mental Health and Substance Use Services. The importance of this transition was to integrate the care that folks inside of the correctional system we're receiving regarding health. And we were wanting to, and I think have, are on the journey of successfully integrating our services into the healthcare system. In addition, there was an idea that we would need to insist on access to other health authority services, such as pharmacy, infection prevention and control, and patient quality. And Provincial Health Services Authority have all of these integrated services within our health authority, which Correctional Health Services has access to. We also have access to provincial health systems such as PharmaNet and CareConnect so that we can provide the continuity of information sharing across our system, and we have enhanced mental health and substance use services within the correctional system. Part of the background for this change was the history of custodial healthcare and the Canadian insistence that we ensure that we are providing prisoners' rights as outlined in the United Nations Declaration of Prisoners' Rights, and that we pay attention to those who are incarcerated specifically in isolation cells. And there has been a lot of work done within BC and with our BC Corrections partners to ensure that healthcare is brought to those folks who are isolated. We also need to ensure that healthcare is autonomous from security. We need to provide care and not custody. And this has been a distinction as we move more into a provincial health initiative across the centers. There are many challenges this brings to the work. Providing healthcare within a custodial setting is a unique challenge and can impose many limitations. And we are consistently trying to improve the healthcare that we provide within the correctional systems. In that vein, we work in collaboration very closely with our BC Corrections partners. However, we do remain with separate policies and interventions and maintaining client confidentiality as a healthcare recipient. We do operate under the BC Mental Health and Substance Use Principles of Care. We're very client centered, and we're going to talk a little bit about that today. And overarching, we always have the mantra of we'd like to move people from the criminal justice system into the healthcare system, improving client health outcomes. We are trauma informed, treating clients with dignity, respect, and always ensuring as much as possible inside the walls that we collaborate with clients and provide them with choice and options related to healthcare and mental health and substance use services. We are very recovery oriented, always having hope and evoking hopefulness in our clients' path and their recovery journey. We are culturally safe and on that learning journey and approach this journey with humility. And we honor our commitment to eradicate Indigenous specific racism in as many ways as possible. We're involved as a health authority and correctional health team in anti stigma work, and we're on the journey from moving from episodic care to a responsive health care system within correctional health services. Just as a brief overview, there are 10 provincial correctional centers in British Columbia. And you can see from the map we're a very large province, in case you're not familiar. We do have one rural and remote center in Prince George, British Columbia, which provides its own separate challenges to linking people as they transition out into communities and move across the northern regions of British Columbia. We have two centers that are located in the interior of British Columbia in Kamloops and Oliver, BC, which is the Okanagan Correctional Center. And these two often have remote and rural implications um, for their locations. Many of our centers are located in the lower mainland, 5 out of the 10. And of course, this is related to urban populations and all of the struggles that we have related to the toxic drug supply and people moving in and out, the lack of housing. There are many, many issues in the continuity of care that we struggle with on behalf of our clients. We have two centers on Vancouver Island in Nanaimo as well as Victoria. and these are similar. In Nanaimo being a little more rural, however, Victoria, very urban setting and struggles with similar issues as we do in the Lower Mainland. There are 10 community transition teams that Cam's going to be talking about that are connected to each of these centers. Inside the centers, the Correctional Health Services team is a multidisciplinary team, and this was part of the change in 2017. We added many resources and many other healthcare professionals to our teams. Briefly, we have nurses, RNs, RPNs, and LPNs, licensed practical nurses. We have some nurse prescribers, and we're moving forward on our journey to include these in our teams, and that's a new initiative in British Columbia. And of course, we have physicians, nurse practitioners, and psychiatrists. We offer virtual care as well as in-person care for those practitioners. We have a mental health team made up of psychologists who offer some virtual care and in-person care, and a mental health team that also has a mental health supervisor who's a master's of clinical counseling position, as well as concurrent disorder counselors. What I wanted to really focus on is those points where people are really invited into thinking about the continuity of care that we have to provide. So, for example, at the intake, each client who comes into a center meets with the mental health screener who assists in identifying critical issues of mental health crises that we can attend to while the person is in custody, and what we call an intake nurse, who's an RN or an RPN, who complete a comprehensive assessment, and they begin to discuss at this point with the client the discharge planning. What are your plans? How can we assist you? This is particularly important at this point of interaction because many of our clients are in for short period of time with us, usually ranging from 55 to 85 days. So there's a very fast turnaround with our clients, and we need to begin discussing with them what hopes do you have for leaving the center and how can we assist. At this point of intake, we actually ask them, would you like the community transition team to check in with you? And at that point, that's when we bring people in. We have access and transition nurses that begin to work with clients to assist in discharge planning, linking referrals to community and health services, and we have seamless referral for continuation of the Hep C treatment options. We have an opiate agonist treatment nurse who assists in transitions, connecting people to primary care options. We have medication reconciliation that occurs at point of discharge. We refer to Indigenous services, and we have the concurrent disorder counselor who assists with treatment referrals. All of these are seamless continuity of care initiatives. You can see on this busy slide that we begin pre-release planning right upon intake. We start to work with the clients in a collaborative way to talk to them about the peers that are available to them, what supports are available upon leaving, the Indigenous services that are available to them, and of course, connecting them with immediate needs upon release, and how we can transfer their oat into the community, talk about safe supply, our philosophy of harm reduction, and of course, we hope that they leave with a prescription in hand so that they can um, continue their healthcare journey.
Thank you, Terry Lee. Good morning, everyone. So Terry Lee has provided a very comprehensive overview of the work that happens within the correctional facilities. And I'm going to be speaking specifically to the work that carries on into community with regards to our community transition teams. So the community transition teams provide support to clients with complex mental health and/or substance use problems leading up to and after release from a provincial correctional center. As Terry Lee mentioned, there are 10 teams across the province attached to each of the provincial correctional centers. And the core work of these teams includes providing transitional support and coordination for those leaving the correctional centers. And this includes both sentenced and remanded inmates. Support also includes, as I mentioned, that in-reach support, so meeting with clients while they're still in custody, which helps to build the rapport and trust for when the client is released. This carries on into the community, where care is provided for up to 90 days post-release. There is a short-term bridging mandate here in order to connect folks back into the broader healthcare system. And the program is also provincial in scope, which is unique, as we have the ability to transfer care across the province throughout our teams. In terms of the program goals, we look at them as broken down into 3 key areas. The first one being reducing. So essentially, we're looking to reduce post-release overdoses and death, reducing harms associated with substance use, such as transmission of bloodborne infections, soft tissue infections, wounds, and other health conditions, and also reducing harms associated with repeat involvement in the criminal justice system. With the second area of the program goals, we're looking to enhance cultural competency by delivering care that is trauma-informed and truly client-centered, enhancing clients' health literacy and self-efficacy, and also overall improving the client's physical and health wellness. The last area around program goals is monitoring and evaluating the development of the community transition teams, specifically looking at areas of improvement and service enhancement. And lastly, looking at the continuum of care and learning about how to strengthen those transitions in care. In terms of the community transition team staffing model, the core staffing model includes peer support workers, social workers, Indigenous patient navigators, and registered nurses, registered psychiatric nurses, and nurse prescribers. All of these folks work as part of an interdisciplinary healthcare team, both in custody, within the correctional center, and also in community. Our staff are correctional health services staff, which is unique and important, as they're able to access healthcare information for clients while they're still in custody, which leads to better care upon transition from custody to community. Our staff also work very closely with our correctional health services colleagues who are providing the care in custody to ensure that there's coordination and continuity of care for clients upon release. And because our staff are healthcare staff within the correctional centers, we also have access to BC Corrections databases, which allows us, to plan for increased client care and continuity of services. Just going to speak really briefly here with regards to the Community Transition Team's Provincial Hub. The Provincial Hub is resourced with additional clinical and administrative supports to assist with client care and transfer of care across the province. Some of the vital supports include having an addictions physician and psychologist who are able to provide much needed clinical services for our clients. This hub model really enables us to better care for clients with complex needs and to be able to better problem solve, be nimble and quick, and also pivot when needed when it comes to increasing the type of care and providing those supports to clients across the province. We are better able to support our regional teams that are situated over the province by acting as a resource to troubleshoot and to provide support and clinical oversight. Most importantly, the role of the hub is really to work towards building better relationships and facilitating connections with regional health authorities and community organizations so that teams on the ground are really connected into that broader system of care and are able to better facilitate care for our clients. Just going to briefly run through a couple of our key roles here in terms of our registered nurse, registered psychiatric nurse, and our nurse prescribers. So our nurses play a key role in bridging care for our clients and ensuring primary care needs are met and OAT is accessible and continued when in community. Our nurses are a key link between our community transition team's addictions physician to address any gaps in care from the time that clients are released from custody This is especially important for clients that have been remanded into custody and are released without adequate time to prepare for discharge planning. Our nurses are also key linkages into community and the broader healthcare system as they ensure that people are referred to appropriate health services and are able to collaborate with community GPs and health clinics. They also work very closely with the medical team within the correctional center to ensure continuity of care. This means working really closely and collaboratively with the access and transition nurse within custody on all aspects of discharge planning and referrals, and ensuring that CTT can help bridge the gap when the client is in custody. Wanted to talk a little bit about our peer support worker roles, as they are integral members of our teams. Our peer support workers have lived experience of incarceration or involvement with the criminal justice system and lived experience of substance use and mental health. They work alongside our other members of the team to help support and provide hope and inspiration to our clients. They are often able to connect in ways that others can't, having been through the system, understanding the system and the challenges. And they really show up every day in a very client-centered and trauma-informed way. I do want to mention, it is much more than just sharing their own story, but they really walk alongside our clients, sharing hope, but also helping to connect clients back into community, navigating resources, providing information on community and health resources, checking in on people when they are in community, and following up when they have dropped off. Also providing transportation and advocating on behalf of clients with community, health, and our corrections partners. And that's just to name a few examples of the work that they do. We don't have enough time to get into all of the different sort of aspects of peer support work, and certainly talking about the hiring of peer support workers into Provincial Health Authority. But I did want to just sort of note there was a fair amount of work that had to take place in terms of looking at our organization's readiness to bring on peer support workers, and what that means in terms of looking at what needs to be done before hiring, onboarding, what are the supports and opportunities that we need to have in place to ensure health and wellness and ongoing training and learning opportunities for peers. I do want to mention some of the challenges, though, that are ongoing in this work, and stigma being the biggest challenge for our peers. And it's a challenge within the healthcare system, within corrections, and more broadly within the broader system of care. And I think it's really around folks not understanding peer work and holding some of those unconscious biases against people who use drugs or are using drugs and have been involved in the criminal justice system. As part of our efforts to eradicate Indigenous specific racism and to provide culturally safe care, we also have Indigenous patient navigators that are attached to our community transition teams. The IPNs, as we call them, are embedded roles within our teams who work specifically with Indigenous clients to ensure access to high quality care that is trauma-informed, culturally safe, and free from racism and discrimination. These are unique positions that have been created specifically to ensure that Indigenous clients are supported to navigate correctional health services and are offered continued support upon their discharge from provincial correctional centres through the Community Transition Teams program. Just wanted to briefly touch upon the ways that we do some of our clinical care work. This program is truly about meeting people where they are at and fostering trusting relationships that begin while that person is in custody. We do assess for risk, but look at ways at which at how we can work with people that may be deemed at a higher level of risk. And this could mean meeting with them in community or meeting with them in more secure locations and providing more administrative support through phone calls and other check-ins. We reach out and try to find clients if they have dropped off by using collateral contacts and the databases at our disposal to determine where they may be residing or last known addresses. And our staff will go to wherever a client is to maintain and foster those relationships. So often that means meeting them in community, meeting them in shelters, maybe it's meeting them in their own homes, but most often it's meeting them wherever they might be on the street, in alleys, and whatever that might look like. As mentioned, we are also provincial in scope, which means we're able to transfer care and support clients across the province. Our partnerships with community health authorities and BC Corrections is key to ensure continuity of care and connection to that broader system of care. And lastly, we continue to engage people and make sure that they are provided opportunities to be part of the program, even if they have dropped off, lost contact, or minimally been engaged. And this really means giving people second, third, fourth opportunities to engage when they are ready, but still providing care, whatever that might look like when folks are connected to the program. And that is everything. Thank you. We've got our email up there. If you have any questions, please feel free to email us as well. Thank you.
Okay, and now we will switch over into the more hepatitis C and STBBI specific component. Thank you, Terry Lee and Cam, for giving all of that overview and intro around the both correctional health services and the community transition team. So I'll be speaking about TestLink Call project specifically. I do have some disclosures. And I'd also like to start by acknowledging all of the people and organizations that are involved in TestLink Call project. I, full disclosure, do not actually do the work. I simply have provided the mechanism for these providers to be able to essentially prescribe a cell phone. And these are the folks that are actually doing all of the boots on the ground connection to care. And a special thanks to the BC CDC Foundation for Public Health, who provide a lot of funding and support. So these are the learning objectives that I will be covering. So really aiming to describe the common barriers that people leaving prison encounter when they're trying to access care for HIV, hepatitis C or hepatitis B. Then understanding the scope and the purpose of TestLink Call project, and identifying some opportunities to remove barriers to STBBI care for people leaving prison in whatever setting, province, territory that you might happen to be working. So specifically looking at the hepatitis C care that's provided in BC Provincial Corrections, there's been quite a lot of changes in the past few years, as Terry Lee and Cam mentioned, both with the transition over to healthcare being provided through BCMHSUS and the establishment of that new Correctional Health Services program, but also introduction of things like the CTT teams. And then we also had a change in the coverage for hepatitis C medication while people were in provincial custody in 2022. And so in 2022, the BC government essentially provided immediate coverage of the hepatitis C medications for people in provincial custody. And we saw that there was a jump in the number of people being prescribed hep C medication while they were in provincial custody, but also an increase as a proportion of all of those people that were identified while they were in custody. And so really important to note that the hepatitis C prevalence in the provincial custody population is about 21 times higher than what we see in the overall population in the community. So 21% of people in provincial custody in 2022 who were tested positive for hepatitis C antibodies. But really encouragingly, almost 90% of those people actually started hepatitis C treatment while they were in custody. And this is key because with this increase, we also need to be thinking about how people will be supported to maintain on hepatitis C treatment when they get released. Many of them would be able to finish because it's an 8 or a 12-week course of treatment for most people. But as Terry Lee mentioned, many people are on very, very short sentences. And in fact, almost 60% of people in provincial custody at any one time in BC are on remand. And the median length of time people spend on remand is 35 days. So actually having strategies in place to ensure that connection is maintained for people, whether it's continuing their medication or they weren't able to start in custody and they want to start in the community. And of course, the CTT teams have a really big role in this, but there's been many barriers identified previously, which are still impacting people after they go back to the community. So some of the barriers that have been identified are really related to stigma and discrimination from healthcare providers. There was a study done in British Columbia that was published in 2018, so pretty recent, that showed that when people were trying to get an appointment with a family doctor in the community, if they disclosed a recent history of incarceration, so they said they just got out of prison, they were more than 2 times less likely to be given an appointment with a family care provider. And so this is a very significant issue that impacts people leaving custody being able to access any healthcare, but especially care for sexually transmitted or bloodborne infections. There's also a lot of issues for people leaving custody getting stable housing and sufficient income. They're discriminated when trying to seek employment. They're also often discriminated when seeking housing. And on top of that, as I'm sure many people in Canada are experiencing, housing is difficult for even people with very high incomes to be able to secure. There's also a lack of awareness for people leaving custody about medications, particularly hepatitis C treatment, or even often around the benefits of treatment. And there's also this sort of lack of knowledge of how to navigate the system. Of course, that's actually something that impacts many people who are affected by STBBIs, but particularly for people in custody, there's often a lower health literacy and a lower level of literacy in general. So that creates a lot of difficulty for them being able to actually know where to go for care or how to access it. And then something that has been increasingly prominent, and I think is a particular problem across Canada, is people not having stable contact information, and often because they don't have a phone, or they have a phone but their phone number is changing all of the time, or they just don't have minutes on their phone. That's a issue that has been frequently reported, particularly from correctional health services staff. When they try to call someone, they don't answer the phone, and then the individual can't call back because they don't have minutes, or send a text message. And so what we're increasingly seeing is that there's this new social determinant of health, which is digital literacy and digital access. And the COVID-19 pandemic really accelerated this and exacerbated it, because so many services shifted to requiring people to make first contact either on the phone or by the internet. And that was, of course, an essential thing to protect staff and clients. But for people who already face difficulties with digital access, whether it be making a phone call or actually using the internet, this has just created another level of difficulty for them, and is now being increasingly recognised as a social determinant of health. So we know that the health system isn't meeting the needs of some population groups, particularly people leaving custody, because we've seen really big gaps in care access after people are leaving prison. And what we've realised is that the services are actually hard to reach for those populations in the community. So we identified that there was a need for equity enhancing interventions that could break down those barriers and make services more accessible. And what we identified in BC was this potential to address the digital divide, and then provide enhanced connection to hepatitis C care. And so we did that through the TestLink Call project. So people who are eligible when the project first launched were people who were diagnosed with chronic hepatitis C infection, and they had either been released from custody, were unstably housed, or were using criminalised substances. And this was originally set up with Unlocking the Gates Services Society, which is a peer-led organisation, all people who have lived experience of incarceration. And as we actually developed the program, we realised a lot of them also had lived experience of hepatitis C. So it made a lot of sense that this group would be able to provide really trauma-informed care for people, but also being able to kind of share their own experiences with doing hepatitis C treatment. And so clients receive a free smartphone with a 6-month calling and texting plan. Then they get that connection to the peer health mentor, and the peer health mentors will support them to be able to connect to hepatitis C care. So whether it's driving them to appointments, helping them get their medications, accompanying them to appointments, or even just being someone to talk to. How this works, particularly with the clients who are currently incarcerated. So Correctional Health Services staff identify clients who need support with hepatitis C, or now we've also added in HIV and hepatitis B, care after release from custody. So they might be initiating somebody on treatment while they're in custody, or they've identified that this person has a chronic infection and they may not be able to initiate them on treatment while they're in custody, but the client is interested in initiating treatment in the community. So they can offer for their clients while they're in custody to be connected to TestLink Call. The Correctional Health Services staff will actually give the clients the TLC agreement. So it's a consent form essentially, and it includes release of information consent. And we had this reviewed by the PHSA risk and legal team because PHSA is paying the phone bill and then we're giving a telephone to a client. We wanted to make absolutely sure that PHSA wasn't going to be on the hook, so to speak, or that clients were being protected in terms of their privacy and release of information. And we've actually made the consent form available on the website so that others can use that as a template if they're interested in implementing something like this. So all of the consent forms and the client materials are all available online. And when they sign the consent form, the Correctional Services staff will also arrange for clients to do an intake on the phone with the peer health mentors in the community so that they can get connected right away. And that allows them also to share clients' health information with the care providers in the community and the peer health mentors. We also can assign a phone number to that client, and that means that the phone number can be shared in advance of them being released from custody as well. And then on the day that they're getting released, one of the peer health mentors will meet them, give them their new phone, help them with any immediate things that they need at the time. Usually it's a ride to wherever they're going to be staying, and then help them start planning for other things that they will need help with, like getting ID, getting started on income assistance, and then of course also connecting to hepatitis C care or HIV or hepatitis B through taking them to appointments, picking up medication, etc. So when we launched in August of 2021, we did hepatitis C navigation training for the peer mentors from Unlocking the Gates. And we had everything set up so that the healthcare staff in corrections could send the referrals for clients while they're in custody. So that was the first component of the program that we got set up. And we have quite a few correctional centres that are regularly referring clients for TestLink Call. And of course, this isn't an either or. We actually have some clients that are receiving care from both the CTT team and from the peer mentors through Unlocking the Gates. And the key there is that particularly, people who have a dual diagnosis, a substance use disorder and a mental health issue, often they actually will require quite a lot of support. And so this is a way that we can kind of coordinate care and make sure that people are getting all of the support that they need. And we were getting a fairly good number of enrollments at the beginning, but it wasn't as high as what we were hoping for or expecting. And so we actually opened up the eligibility at that point. So that was when we were also including people in the community who were at risk of becoming incarcerated. And so really also trying to close that loop. And so we also have phones that are situated in community clinics or other community services. So if they're identifying clients, then they can also provide them a phone on the spot and get them set up to connect to services. And then we also started holding community pop-up testing and linkage to care events, and really focusing on communities where they're often not a lot of other services. So we really focus out in the Maple Ridge area, which also happens to be where there are provincial correctional centres. And so often it's people who have been released from custody, but they were either not willing to connect with services at the time of release, or, you know, for whatever reason, just didn't. And then we can try and actually bring them back into care. So the program had its second birthday at the beginning of October, and as of the 20th of November, there's 281 clients enrolled now. Actually, quite a lot of them have been identified by the peer health mentors in the community. And we also have been able to ensure that when people do go back into custody, that there's communication and sort of coordination of care from that direction as well. There's now 16 organisations that are part of the network where they have phones, and they cover all of the health authorities in BC. And we know we're really including people who are facing difficulties in accessing care, because almost half of the people enrolled had no fixed address or were unstably housed when they were enrolled. And almost 40% were currently on opioid agonist therapy when they were enrolled on the program. So we've done an evaluation of what the impact of TestLink Call is. And we found that among the TestLink Call participants who'd seen the treatment provider and gotten a prescription, 81% of them had started Hep C treatment in less than 6 months of being enrolled in the program. And when we compare that to what we see at the overall population level in BC, we see about 59 to 60% of people who inject drugs initiating treatment, and 73% of people without a history of injecting drug use in BC starting treatment. So we're actually doing better at 81% treatment uptake than what we see overall, which is really encouraging. It shows us that this model is effective. And we've also seen that there's not a lot of difference for people in sort of completing blood work or getting through those stages of care, whether they were already connected to a clinic or they were brought in through a peer health mentor. But we do think that the peer mentors are really important, because they've been able to identify so many people in the community who already knew that they had Hep C infection and hadn't been previously linked to care. And we also did a qualitative evaluation to try and understand how TestLink Call was supporting clients to engage in care. We found that the sort of first theme was fairly obvious. It was improved convenience in accessing care and other services. And that was really something that we were hoping we would see. We were expecting that by providing the phones, we were enabling people to be able to do telehealth appointments, and then having that peer support as well, really supporting them to actually show up to their appointments. So it was really good to see when we did the interviews with clients that was actually how things were working for them. Interestingly, we also found that there was this enhanced communication and trust. And trust was very important. It was a strong theme, and it came up a lot for clients. And this is something that I think, particularly for people who've been incarcerated, they've often lost trust with the system. They've experienced a lot of stigma and discrimination. And so building back that trust is actually very important if we're trying to support them to engage in services, because often the reason why they're not engaging is simply because they don't trust them. We also saw increased motivation to change or to start Hep C treatment. And this is also really important, I think, because it's one of the ways that we think that this intervention is actually improving other aspects of people's health and wellness. Really important was increased social connection. We were focusing on sort of very practical aspects and really hoping to increase connection to Hep C care, but increased social connection and especially contact with people's family and their children is very, very important. And we think it's a way that we can sort of further amplify the benefits for people from this intervention. And finally, all of the participants in some way shared this elevated sense of personal value. It felt good to be receiving something like a fairly expensive smartphone. And people felt that because they were receiving something like this, that there was a reason why, and that they felt valued, they felt respected. And a lot of people shared that it was just a boost. It was the first time for quite a while that they felt like they were important or that they mattered. And I think this really can't be underemphasized when we're thinking about how we can support people who've experienced incarceration to connect to care. There's other benefits as well, because we put apps on the phones before we provide them to clients. And one of the apps that we install is called the Lifeguard app, which is an overdose prevention program. And we know of 2 accidental overdoses that were attended to by first responders because one of the clients was using the Lifeguard app. And then, they can enjoy just having their own phone. And some of the benefits of that is that they can text me. I get a lot of text messages from clients because my name is actually on the account. All of the phone bills are in my name. And so I'm the only person that can authorize changing someone's service or releasing their line. And originally it was a little bit frustrating that was happening, but then after I started getting these kind of messages from people, it actually now has become something that I quite enjoy. And often it's because I'm getting these messages of appreciation. These are screenshots of actual text messages that clients in TestLink Call have sent me. And the other things that I think a lot of us take for granted is just the ability to call 911 in an emergency, to make video calls for a court appearance, or just to listen to music. Having a phone is, in 2023, something that is by many people seen as essential, but it's actually out of reach for a lot of people in our communities. So our impact evaluation was, I think, very conclusive and clear that providing cell phones and connection to peer health mentors to people who experience criminalisation is an effective strategy to enhance connection to hepatitis C care and treatment uptake. And so in June of this year, we expanded the program to include HIV and chronic hepatitis B. And the round of monitoring and evaluation that we're doing at the moment, we're redoing client interviews with healthcare providers, including some of the correctional health services staff, as well as the peer mentors. We're also going to be looking at the impact of engagement in HIV and hepatitis B care, and then exploring the additional benefits of being in the program. So we'll be looking at whether people were able to get housing or if they participated in other healthcare like cancer screening. And we sort of see this as part of an overall kind of shift in the way that we're trying to think about STBBI care. And whether it's a virus like HIV or hepatitis C, or even syphilis, it's moving away from treating the infection or treating the virus and trying to treat the person. And this really aligns with the way that BC Mental Health and Substance Use Services and Correctional Health Services are also trying to shift the way that care is provided. So really focusing on person-centered, culturally safe and trauma-informed care. And this type of intervention is a really useful tool for providers to be able to provide person-centered care. If people are interested in seeing the impact evaluation report, it's available online. This is the web address, and my email address is also there if people have other questions.
Thank you so much, Sophia, Cam, and Terry Lee, for your wonderful presentations today. We are a little bit short on time, but I think we have time for maybe 1 or 2 questions if attendees have any. As a reminder, you can submit your questions through the Q&A tab at the bottom of your screen, and you can like other people's questions to push them up in priority. Not seeing any questions right away. There was a question submitted upon registration by an attendee previously. And this question was for Cam and Terry Lee. And this person was asking if you could elaborate on the correctional transition or community transition teams and their involvement in linkage to care upon an individual being released from correctional facilities. You had mentioned that the CTT works as a health navigator and it also provides clinical care work. Perhaps you could touch a little bit on some of the services within clinical care work that are offered to these clients after they have transitioned.
Sure, I can speak to that. I guess it could really mean anything for an individual based on what it is that they're wanting, needing in that moment. And so just a few examples, that might look like connecting to our physician. They might have some outstanding primary care needs that they need taken care of. They might need prescriptions for a referral to a treatment center. So they're waiting to get into treatment and they're going to need that prescription. It might mean, transportation. When you look at sort of the geography of British Columbia, you have people that might be incarcerated in the Lower Mainland, but are actually, their home community is in the interior. And so they're being released. They have no way of getting home. It's not good for them to be out here. They need to sort of have someone, get them back home. And that could be what our teams are doing. So you might have our Lower Mainland team who's going to drive halfway, and our interior team that's driving halfway, and then picking up that person and carrying them, taking them back home. So it really could look like anything. And so again, it's really that focusing in on what does that person need, what is it that's priority for them, working with them while they're still in custody to better understand, and then being able to provide that support when they're out in community.
I can give a hepatitis C specific example too, because I was chatting with one of the peer workers with the CT team last week, and he was telling me about a client who he was supporting, who was doing hepatitis C treatment, and who was actually enrolled in Test and Call project. So the client had received a phone, and Steve had actually picked him up, driven him to his appointment at the care centre in the community that was nearest to where this client was residing, and was supporting him while he was doing hepatitis C treatment. So from a very practical perspective, it's literally coordinating those appointments for the client, picking up his medication, and really just ensuring that the medication that was started while in custody, so for this person it was the DAA treatment for hepatitis C, that medication was going to continue to go with them when they got released, and then follow-up appointments would be able to be attended to. And so really ensuring, as Cam and Terry Lee both mentioned, that there's that continuity, but also that, whatever the needs for the client are, that they can help them with that. And so for this particular client, it was hepatitis C treatment.
Thank you both so much for answering that question. I think this is a good time to end, considering we're nearing the end of our webinar time. I'll just share my screen for the last slide for today. All right, so I would like to thank our speakers for the presentations today, and thank you all for joining us. We hope the information provided will help you in your practice. Please fill out our short and anonymous evaluation survey, which will be emailed to you after the webinar. Your input, comments, and suggestions in the survey will help us plan our future webinars. The recording from today's webinar will be available on NCCID's website. And lastly, please join us on Wednesday, December 6th at 11 a.m. for our next webinar in this series, titled Canada's Prison Needle Exchange Program, Lessons Learned and Accessibility Barriers. Thank you all and have a wonderful day.